So we do have a financial interest. I'm a Trabectome trainer. First I want to talk about the background of this technology. There are many misunderstandings. It's always funny how people think this is cautery. It is not cautery. The technique and the post-op care, which are very straightforward, they're not much different from cataract surgery, except the pilocarpine. I want to show you new outcomes, which I think will enable you to see the range of new indications of trabectome surgery. First, minimal invasive glaucoma surgery versus trabeculectomies and tube shunts. What are the differences? Why, I think, is it a duty for us to learn it, whether it is this particular one or other minimally invasive ones? Why do we owe this to our patients? I think the answer is quite easy, but I think this slide always summarizes it very dramatically, why we really have to do better. These are, of course, all the side effects of hardware that we implant and of trabeculectomy with a powerful antifibrotic, mitomycin. You can see here such delightful things as a flat chamber in the left upper corner, or a leaking bleb and kissing choroidals, and something that's more common perhaps at UPMC, where we do perhaps more tube shunts than at other places, erosion of hardware. And not just erosion, you can aspirate things. This is actually vitreous being sucked into a tube tip. This is a blebitis. This is an endophthalmitis, and remarkably 9% of your patients will get an endophthalmitis after trabeculectomy over many years. That's a high number. And then of course scleral melting that can also occur after mitomycin C. More appropriate perhaps is the comparison of minimal invasive glaucoma surgery and trabeculectomy or tube shunts to what phacoemulsification was to extracapsular cataract extraction. And by now we know we're in the middle of this paradigm shift that we can operate earlier, because minimally invasive glaucoma surgery does have a much favorable range of side effects. But if you compare this, one is high-tech, you do need to invest into a device, or you have to implant little micro devices. And the other thing is low-tech. Extra cap doesn't require as much high-tech as phaco, or especially intracap, if you want to include that. One is appropriate for moderate disease, although I think it is also appropriate for advanced disease, while the other one is more appropriate for advanced cataracts or advanced glaucoma. And so on and so forth. Small incision, large incision. Safe, complications due to the large incision, among others. Predictable, standardized versus very variable. And there are a range of minimally invasive glaucoma surgeries. You've already seen many of those from right to left according to angle access. And I will show you in a second what that exactly means. But basically, you have devices that tap that have sort of a single point of access to the drainage system, the iStent perhaps being the most prominent one, and then the second generation. The hydros is a scaffold, but also has a little snorkel that reaches into the anterior chamber. And then, of course, the Trabectome, with which you can skip lesions in the blade and go as long as you can, while you get here a little less. And then we've already seen, doing the AGS now, the Zen, which is a silicone or gel stent that shunts liquid aqueous humor into the subconjunctival space, and then something that's quite similar but more rigid, because you can stick this into the suprachoroidal space. And then we have others that might not be quite as minimally invasive, the gold shunt, for instance, which is a suprachoroidal stent. So what are the differences? They're actually quite striking. And I've labeled this slide 240 versus 60 degree, which is sort of a little confusing. Let me show you where these degrees of angle are sitting. But first, let's take a look what this is here. So, I think you were in Austria, and you might have encountered this. This is a laser that ablates the trabecular meshwork over a 200 micron area. So it is a procedure that is device or implant free, doesn't leave anything behind in the eye. Then we have these teeny tiny, this is to scale by the way, teeny tiny micro stents. One of the problems of those is that up to 20%, the second generation, cannot be found in the eye after implantation. They end up somewhere somewhere, basically, in the sulcus, pulling through the meshwork in the outer wall. This is the iStent first generation, this is the Hydrus, and this, of course, is the Trabectome. Now, what you see here in the background is a, you could call it canalography, but it really is an SD OCT scan of our glaucoma imaging group, which allows you to extract the voxels of aqueous spaces. And different from the textbooks we've used to learn about the eye, this is Schlemm's canal, and is not continuous. That's the reason why, if you have done canaloplasty, you've always wondered, why can the canal not go around? That's the reason. Discontinuous areas here, and here we have sort of a duplication of that. And now you can imagine, if you tap with a little snorkel into the wrong space, you might not get any flow, while with others you can skip lesions and just go, go, go. So that still doesn't explain the 240. Well, according to a publication by Rosenquist, and this is actually some time ago from, I believe, the 80s, a single axis lumen gives you flow over about 60 degrees. And that means if you ablate about 180 degrees of circumference, you get flow beyond this. So 180 plus 30 and 30, that gives you almost circumferential flow with a trabectome. And the outflow tract is very complex, very complex. This morning, Dr. Wang showed images of fluorescein angiography, and my lab has done something very similar. But basically, these early drawings of neoprene casts that we see on the left are in actuality even more complex. You might not even recognize these vessels here. There are arterial vessels that are just posterior to the outer wall of Schlemm's canal. There are vessels that are collapsing readily. There are venous loops, a fairly delicate, a very delicate anatomic structure. It's not this big infinity pool overflow system. It's a delicate living tissue. And that's the Schlemm's canal. That's where you have to stick the microstents or the trabectome, down there. Good, so how does the device work? Well, this is the tip. You can easily make out, even when you look at, through the microscope, the two different electrodes. There is the return electrode, a golden round, I'm sorry, this is the active electrode. The return electrode is actually just posterior to that. It's sort of a lip. And then there's an aspiration port up here. And you have a large oval-shaped irrigation port for inflow. That maintains your chamber quite well. You maintain the chamber stably. You have a well-pressurized environment. You can easily remove debris, blood, anything that you might be encountering. That makes it very versatile. You cannot just ablate the meshwork. You can also break synechiae, get access to the meshwork, and then ablate and remove things. There's a footplate that is quite important because this is plasma surgery, as we will see in the next slide, which is quite different from just cautery, which you might be used to from, well, cauterizing blood vessels. This handpiece connects to the pump and to the generator, a high-frequency generator, and then there is this foot panel, which works pretty much like a phaco pedal. You can click it on with this black ball, that's the continuous flow, and then as you depress the pedal, you engage aspiration, and then you will hear an audible sound that indicates that the ablation is activated. The proper term for this would be a bipolar 550 kilohertz ablation. It creates sort of a picolightening, and that in return creates a microplasma bubble. That sounds dangerous, but it's actually a good thing because plasma is something you already create with your lasers, with a YAG laser, for instance. It's the fourth state of matter. It's a high energy state of matter, and it has a very circumscribed cone of heat dissipation. It doesn't dissipate very much because anything beyond this has a very low state of energy. So that means, although you're dealing with plasma, which you might see in, I don't know, nuclear fusion reactors, you're containing this in a very circumscribed space, and there's really only a heat transfer of 1.2 centigrade to the outer wall. So you're not burning anything. If you see carbonization, that is too much energy. You have to click that down. Usually you ablate at around 0.8 or 1 maybe on the trabectome unit. Now what you see here on the right is what you remove. That's the primary pathology in open-angle glaucomas. Whether that is an increased resistance to outflow, myocillin overexpression in steroid glaucoma, or anti-VEGF antibody, or pseudoexfoliation, or pigment dispersion, you remove it. And that makes it so specific and such a nice procedure, I think. We're not affecting anything else. We're removing a pathology. And we're not leaving anything behind with this ablation technology. We're not leaving anything that could incite fibrosis or foreign body reaction. Good. So meshwork is gone here, before and after. And what you see here is you're sitting in the anterior chamber. You're looking outward towards the outer wall. This is an electron microscopy image courtesy of the late Doc Johnson from the Mayo Clinic, with who I trained. And you don't really see a lot of collectors. Where are they? Well, take a look at this one here. Take a look at this one here. This is the superior lip, and this is the inferior lip. Now the question that people always ask, and that I ask myself when I see this GAT, this suture ripping off the meshwork, why didn't people do that earlier on? Actually, people did this many, many decades ago. This is trabeculotomy, and it works really well in children. Or we use goniotomy, but not in adults. We use that in children. Why is that? Why does it work in children and not so well in adults? Well, the answer is that the posterior scleral spur is fairly rigid in adults. But in children, if you've ever done a goniotomy, or I encourage you to Google this on YouTube, there's a very dramatic snap back off the scleral spur because it's so elastic. So the two lips of meshwork, they're not adjacent anymore, they're wide open. All these anterior and posterior collectoral orifices, they can get potentially blocked in an adult eye because you have your lips, they roll over. So we'll see what comes out of this resurgence of these surgeries that really have been done for a long, long time. In this case, you don't have to worry about it because it's removed. And there's a problem with devices. And this is a picture that's not very well known. And on the left side, what do you think is on the left side? Any takes? Any guesses? You've seen them a lot, I think, in this meeting. This is actually the eye stand. And you would think this has to be more of a half pipe, perhaps, but you see it's not really half pipe. It's a relatively small lumen. And you see other things. There's fibrosis or stuff that's blocking a big part of this, although this was an expert implantation by people who are very, very good with this. On the right side, what do you think that is? This is not the eye stand, and this is not the G2. This is actually a scaffold device. This is the hydrus. And the idea there is, you can see the difference. So this is the claim to fame, that you're spreading this lumen open to allow a lot of flow. But if you show this to a cardiologist, to an interventional cardiologist, would you ever shove a stent in an eye and not know what's surrounding it? That's the problem here. You're compressing collectors. Because you're spreading things open, you're compressing other drainage structures potentially that you're not aware of. What glaucomas could you address with angle surgery? Let's just call it angle surgery. Certainly with a trabectome, you can have a very high success rate with primary open-angle glaucoma, with pseudoexfoliation, steroid-induced, anti-VEGF agents, whether this is clumping of antibodies or silicone oil. We've heard many theories why people get that, or whether it is just sclerosing of the meshwork itself, because that's what actually anti-VEGF can do. Acute angle closure works well also. Chronic angle closure works quite well. If you do your goniosyncytial, you can build this actually as a goniosyncytial, as a trabectome. But there's a third thing that you should do with angle closure, and that's, of course, cataract removal. Low pressure glaucoma, always a bad thing to have, and you know that the theoretical limit of this surgery is, of course, the pressure of the episcleral veins. Whatever's on the other side of a meshwork has to be the theoretical limit. So that means if you get glaucoma damage in the patient with 10, chances that you get a 30% drop are not that high. On the other hand, the risk profile is so benign, and if your patient has cataracts, why not trying that first and see what happens? Because you actually can get a pressure reduction in some patients. There's one group of glaucomas that is not listed here that can potentially affect the collector system. Anything with bad uveitis, autoimmune type of things where you get scleral changes, that might not work so well. But as I will show you on a later slide, if you have not the world's most aggressive uveitis, this can work quite well also. The complications are hard to find in the literature, and the reason is that what is called currently a complication in the literature is a pressure elevation, often the result of retained viscoelastic or of a blood clot over the ablation site, and this can create a pressure elevation of 10 millimeter mercury and sometimes beyond. And it affects about 3 to 10. There is always a hyphema. Hyphema is a good thing. If you have a patient with blurry vision and they say, gee, doc, my vision is terrible. I thought I would have better vision, especially since you removed the cataract. Tell them that's a good thing. It means the outflow system is patent. There is backflow. And of course, the more you unroof with a trabectome, the more likely you are to get flow back. If you think now what I've shown you before of a single access devices, less likely because you're accessing fewer collectors. Now compare these complications to the TVT study, perhaps the best designed comparison of tubes versus traps. Manipulation needed was in 74% of traps and 27% of tubes. That's a lot. And of course, this is maybe not the most fair thing. Manipulation includes cutting stitches, but it's a manipulation that you do not have to do here. These numbers sound high, but if you talk about vision-threatening events, look exactly at the numbers. When you add them up early and late in the TVT study, that's a lot. 77% in traps. This is actually shocking, and I think maybe the biggest reason why people now tend to migrate to tubes is that maybe the complications are not that bad. Within 5 years, that's how much you get. It's quite a bit. Quite a bit. If you were buying a car and someone told you you have 33% of that and still working and not having a major breakdown, you probably wouldn't get that. Okay, so here is what this the reduced chance of complications means. You can be an aggressive glaucoma surgeon. You can do this early on. If your patient has 20/50 glare vision or wants to improve his vision and has anything from just high pressure all the way, in my practice, to advanced glaucoma, I usually recommend trabectome surgery. And if there's astigmatism, you can safely put in a toric lens because you're not inducing any astigmatism that is unpredictable. You have a surgeon factor. You can't get a surgeon factor from tube shunts or trabeculectomies. Technique. The most important thing I think for you is to make it easy on you and use a great microscope. If you schedule your first case with a bad microscope that doesn't tilt so well and that doesn't have a good light source or poor optics, don't use that. You wait until you get access to an operating room with a great microscope. And if you have one that has xenon light, even better. Xenon light has a better color rendering index. It brings out translucent tissues that are hard to see much better. And it's a bright, crisp blue light, and some people find that annoying. It's like the beams in the back of when someone is behind you on the highway. It's that annoying, but it's an advantage to have it in the eye of your patient. Don't use visco at the start. Every beginner wants to form and maintain the chamber with visco. Don't use it before trabectome surgery, and I will show you why. When you go in, you do want to induce hypotony because that allows you to identify Schlemm's canal very easily. It's the flow back of blood that stains the canal, and you can identify. Technique-wise, you will have to make the incision quite anterior and a little flared. That way you don't create striae and you see much better. Don't push outward. Think of this, have the pride of a retina surgeon. This is like you're peeling a membrane, a retinal membrane. Don't push outward. The holy tissue of outflow is right microns away from where you operate. You want to get in and maybe even pull inward a little, but you don't want to make the common beginner mistake that I see all my new fellows do. You push because you want to get into the space and you want to stay there. Wrong. Ease up, take a deep breath, and follow the canal. And try to ablate as much as you can, but don't force it by any means. You want to have comfortable visualization, but don't limit yourself to just, a little left, a little right, you're done. Do a good job. Access more collectors. Now you want to have happy patients as early as possible, and you can do this by retaining some viscoelastic. That pressurizes the chamber well. That prevents the flow back, and that means you have almost no hyphema. So let's take a look at these steps. This is a video that summarizes these steps. Going in, flaring. You can see this is quite anterior, more anterior than your typical cataract surgery. I like the Zeiss Lumera. I don't have a financial interest, but this has very nice crystalline light. Burping the wound, inducing hypotony. Lens on the eye, where's the canal? And you can see this here now, and I will show you this on a slide. What you might have thought is the meshwork. And then engage to the left. This is a much better angle of attack here. Point up slightly if you can. Once you get better, this makes it easier. This is sort of a Zen moment. Deep breath and in. Steady hands. If you're nervous, take timolol under the tongue. It works magic. It's not a placebo effect. And this is a non-pigmented eye. Basically the same pattern in, and you start, and you don't want to see the eye spin with the ablation because that means you're stuck on the outer wall. Then I try to go as far as I can. This is 1.5 times as fast. I should slow this down because there's no need to erase it. It does not have to be continuous. I'm lifting this up to show you can do 180 because some people say that's not possible. I don't know why it would not be possible. I think people confuse the fulcrum and the sort of basic shape of the eye. And you don't need anybody to counter-rotate the eye. This is not goniotomy. And then tamponate this. I like Discovisc. I don't have financial interest, but it is a combination of a cohesive and dispersive viscoelastic that allows you to push visco into the collector channels. Stepped incision, but you're using the same incision and create sort of an inverted smiley like a scleral incision for an extra cap, if that's what you use for extra caps. And you can wiggle yourself in. And then again, cataract surgery, you tamponate after this. The tamponating is done so you minimize the clot along the ablation side. That gives you better early flow and better vision early on too. Now you can put in your lens. People say, "Why? I want to do the cataract surgery first because there's all this blood after trabectome. I couldn't see the axis," but as you can see, that's absolutely not the case. It's pressurized with viscoelastic, and you can do anything you want, basically. And I like to retain up to 30%, but be careful if you have someone with very advanced glaucoma. The occasional patient can have somewhat elevated pressure. Personally, I think it is safe, like an Ahmed, where you put in a little viscoelastic to form the space. Good. Okay, now let's look at these steps in detail. Visualization. You see two things here. Large tilt. Don't try to counter-rotate the scope, the patient on the shoulder. I will show you what happens if you do that. And not all scopes can do that. We have a Leica, one old Leica that I hate to my guts whenever I get it accidentally, because you have to sort of shift tilt it, loosen a screw, and then it falls towards you, and you can't get it back for the cataract, and it's a mess. This is the enlarged side of the gonio lens. There's a left-handed and a right-handed. And this is a good scope versus a bad scope, and I don't want to scare you with this, but it's sort of curious to see this. This is a Lumiere here on the left with xenon light. I think that's the only xenon system in the US market, but I might be wrong. This is a not so good scope, and it has a lot of movements. And you would see something in a second that's quite disturbing. You should never see blood flowing back while you're in the eye. Because remember, the bottle is high, the eye is pressurized. And why is the patient moving so much? Well, this patient is lying on the shoulder. The microscope didn't tilt enough. There's blood. See that here? Where's this guy? I'm stopping now. I'm saying, where's this coming from? It means I must have hit something arterial that's more pressurized on my infusion. Terrible setup. But basically, that allowed me then to argue we need better microscopes. Head tilting away, microscope tilting towards you, not quite a 90-degree angle of the two, but you tilt the microscope about 30 degrees, and you tilt or turn the head. That does not always work, of course. So you might have to tilt a little more the microscope. Rotate the head in the opposite direction, the microscope towards you. Surgical steps. Flare the incision or nick Descemet's membrane. Gives you much easier range, no stria as you go to the left and to the right. I like to make it anterior. You know that many of your patients have floppy iris, and if you create a short incision that's anterior and designed to give you a good range, that means you can easily incarcerate iris. We had a colleague who always would insist making this incision flush at the limbus, and he was always fighting iris. And you can get hooked in the iris with this instrument, make it easy on you, anterior incision, short length, and flared on the inside. Gape the incision. I think this is actually a picture that, or something that you discovered early on. Inducing hypotony. You would think this is maybe the meshwork here, right? This is pigmented. It's not. This is actually the ciliary band. If you hear horror stories about high pressure of 50, almost total hyphema, patient needed to go to the operating room within days, trabectome doesn't work, these are people who have confused the meshwork with a ciliary body band. If you ablate that, you have blood everywhere and it has no way to drain. So make sure you identify the right structure. Almost invisible here, easily identified with this gaped incision that creates hypotony and flowback. And then try to engage a little to the left. We will here today engage flush the meshwork because it's easier in this wet lab. But you would see, this is a more pointed angle of attack that makes it easier to get in. And then point up. This is true also for microstents if you will ever have the pleasure to use those. Basically, you want to point up at the level of the scleral spur, and then you're almost plopping into the space. It's maintained like a tent due to the scleral spur, and if you were pushing flush against it, you're collapsing the space, and it's harder to engage. But keep in mind, pride of a retina surgeon, you're now a minimally invasive glaucoma surgeon. This is not a tube shunt. This is not a trabeculectomy. You have to have a completely different mindset. Don't push outward. You have to treat this like this as sort of a holy grail and really delicate. Don't push outward. Okay, here's that again. That Zen moment. This is the most important step. That's what I want to show you again. It's very easy. It looks easy. It's easy to learn. Up. Straighten it out, then you can pull inward a little. You want to make sure you're in the right space, and then you start. Same here. You go in. You have a very sort of direct view, and you can also see that I'm floating the lens in this bath of BSS. Now, if you had a lot of viscoelastic in here, you would trap these plasma bubbles. And if you have a lot of viscoelastic on the cornea, that creates these optical interfaces, and you would not see so well. This is the hand position. I'm actually not even holding a trabectome here. This is just a big pen. And that's how it feels. You go to the left, and then I don't pull it back out. I would encourage you to keep the trabectome in, rotate it, walk yourself around. You can use the gonio lens to stabilize yourself and roll it to the opposite side, tip down. And then you go to the right. This is awkward. This is a little bit like tennis backhand, not the most comfortable thing if you start out at, but very learnable. What happens if you pull it out of the eye is you have backflow, hyphema, and then you can't see. Basically, if you lift the heel up, you have an even more direct view because the surface of the gonial lens is now facing you directly. You don't get this light scattering, chromatic aberration. So float the lens, you know, your best gonioscopy skills forward. All right. And again, this is this fascinating view of what this drainage system really is, and why with this device you can skip these lesions and just go on and on and on and on and tap into as many outflow segments as you want. You could even reseed and work across the nose, which I've done a few times. I'm not convinced yet that it's more effective, but it's possible. Good, but is more really better? This is a poster of Dr. Alfer Sitt from the Mayo Clinic, and the poster concluded that really longer is not better because it's not statistically significant. But you can see here that it actually does correlate, and it's just sort of missing the significance barely. Is longer really better? Does it give you a lower pressure? Probably not, but maybe little. I think what it does do is it increases your chances of connecting to one of these collectors with success. It's sort of a stochastical problem. You know, better chances, basically, not necessarily a lower pressure. Okay, so after trabectome, let's review this. Tamponade with a viscoelastic. You want to choose something that has a little staying power so you're not burping everything out there. Then enlarge the same incision, do your phaco, tamponade again, and then you can implant the lens, put in a CTR for an unstable lens in a glaucoma patient, and then leave some viscoelastic in there in the end. This is how you enlarge. You go in, you push down with the heel, almost flush against the sclera, and then you walk yourself in to get that U shape of the incision. There are many other ways of doing that, but this works quite well. I don't use sutures. I know people do. I find when I pass a stitch, I induce hypotony. I get flowback, sort of a thing that I want to avoid. Or they get easily confused if you want to have low pretinol and this and that. And so I try to keep my drops for phaco and trabectome the same. I use Pret Forte, and the only difference is that I add pilocarpine to constrict the iris away from the incision site. Pilocarpine for a month, 4 times a day, gives you a small pupil. Then 3 times a day for another month. And sometimes if patients had floppy iris during the surgery, I'd like to do it another month, but I don't think it's absolutely necessary. Steroids can be tapered quite quickly, actually. 4 times a day for a week, 3 times a day for a week, twice a day for a week, once a day for a week, and then off. That's faster than phaco. And it's probably because the meshwork is not there anymore. And you will remember the meshwork actually has Kupfer cells and other cells that can do antigen presentation. So that cycle of iritis spiraling sort of out of control is cut out because everything in that drain drains straight into the pipes without going through this strainer that can cause antigen presentation. Visualization, we said, get a good microscope for your first cases, no viscoelastic, induce the hypotony so you know what you're going for. Technique, anterior incision, flare it, don't push outward. That's where the collectors are. Ablate as much as you can comfortably do, and retain some viscoelastic if you want to have good vision early on, but not really necessary. Let's see how your first cases might look like. These are our current fellows. I want to show you this because you will get upset with your first cases. You will have a tremor, I suspect, and you will be upset with that. And it's different from cataract surgery. Be prepared that although you're an experienced surgeon, this is a little awkward initially. You will need maybe, look at this nice hyphema. This is very nice here. Hyphema, flow back, interschlems canal. Perfect. This is a left-handed surgeon. She has a different gonial lens. You see that? And you see these movements. I can hear the cursing. Okay, but you know what? My right-handed fellow is getting getting to about engaging. They're both nervous not to hurt the root. Take your time. This is not terribly dangerous. And sometimes people say, well, couldn't I cause a cyclodialysis cleft? So the cleft that you know from your hypotony cases is from a large cleft that is very deep. If you slip there, nothing terrible will happen. This is not going to cause hypotony. Yes, you might disinsert the iris root over, I don't know, 5 degrees or something, but it's not terrible. So here, both are very happy. But finally, this is going here. So let me show you what happens when they now do this backhand. You can see a whole lot more wiggling. Here, there's more tremor. There's more air bubble. It doesn't know quite where the beginning is here. And let's see what she's doing. She hasn't actually turned this around yet. So be ready. This is case number, I think the first case actually of these, and they're fabulous surgeons now. They've done 50 cases and they're great. Good. Outcomes. Global outcomes, 6-year outcomes. Quick comparison. Does it work? Yes, it does work. This is 1,400 cases, phacotrabectome. Phacotrabectome cases, whenever you look at these graphs, you might have wondered, why is this higher? Why is this lower? The red line being the baseline, and the reason is they have a different indication. This is a mixed indication. These patients have a cataract, want to get the cataract out, and while they're getting the cataract out, they also want to get off medications or get a lower pressure. These patients here, they have only an IOP indication. And so basically you see that both sort of drop close to 15, and there's a medication reduction here in this group because they can, and these patients cannot so much. Global outcomes, this here suggests that trabectome alone might be less effective, but keep in mind this is not an RCT, so this is not fair to say simply because these patients had a different indication to start with. This does not mean that you will have to lose money by combining these two. If a patient has a pressure indication, you can do trabectome alone. That does not mean that the success outcome will be any less. And don't want to bore you with too much data, but basically most experienced surgeons have very similar results, about 30% decrease. Some have more depending on how high the pressure was, and so on and so forth. 6-year outcomes, actually this is the oldest minimally invasive glaucoma surgery. Now 10 years old, and there's 6-year data. And it lasts. In some patients it lasts a long time. That's encouraging. We're not limited to just 1-year data. This is trabectome versus trabeculectomy. And again, this is not randomized. This is a single surgeon, Dr. Brian Francis, and you can see that he achieves incredibly low pressures with trabeculectomy. My trabeculectomies are not at 10 or so in average. They're more close to 15, and you will know from the TVT study that's actually very similar to what you see here for trabectome. And his survival curve is actually very similar. Trabeculectomy and trabectome, but trabectome is better. That doesn't mean that it's necessarily better. Keep in mind, they're different indications, but it's clearly a very good procedure for your patients. Now, this is always the argument, but trabeculectomy is the gold standard, but it's better. Now, let's turn this around. Can we do trabectome after trabeculectomy? Trabeculectomy with mitomycin C. And yes, we can. This is actually surprising. And the classical teaching is these collectors will atrophy and there's not going to be any flow. But why would that be? Think of your sink at home. It's not like the drain atrophies and is gone or something. It's still there. So if you remove the strainer tissue, you can get a drop that's at least somewhat similar to eyes that have not had any drainage surgery that you saw in the prior data. So if you have someone who really does not want ever to get 5FU injections and needling and all this, consider that. It works. And what's even more interesting, in advanced, this is not statistically significant, but it's intriguing in that the advanced glaucomas get a bigger pressure drop in average than the not so advanced glaucomas. Maybe that means the meshwork is more diseased, and if you remove more disease, maybe you get a bigger pressure drop. All right, scatter, but this is probably too much data here. And yes, people did need to be advanced, of course, but there weren't that many advancements for secondary procedures. In this study, trabectome after trabeculectomy. Another thing that's sort of interesting, I always thought that if you remove the lens, you get a much deeper angle. That has to be good. Probably prevents unicular closure. So what you see here now is AIT stands for trabectome only. Phaco AIT is cataract surgery and trabectome. And here you see your Schaffer grades, pretty narrow, less than 2, and wide open, more than 3 for both these. Let's see how that pans out. Again, not randomized controlled, but sort of perplexing because these trabectome patients did not have their lens removed. They essentially remain narrow. What you see at SG2, the black line, these remain narrow angles. And they're no different in this retrospective study. It's quite striking. So you don't have to remove. In fact, this is what people in Germany do. I always thought this was a missed opportunity and maybe not so good, but hey, you can do it. And it's not really much different. You can see here, AIT and phaco is not different. So consider that. There are some patients with very high pressures. No reason to say, gotta do omics. That's the only thing that works for acute pressure drop. No, you can do that. You can just do a humble little trabectome and a procedure that takes a few minutes. Survival plots, narrow angles, quite as good, almost as good as wide open angles with trabectome only or combined. Good. Type of glaucoma, I think this is our last slide before we do the wet lab. Pseudoexfoliation. Oh, you gotta love pseudoexfoliation, you know. So responsive. Look at these traumatic pressure drops. Boom. And you got the lens out of the way, reduced pseudoexfoliation material produced. So that, if you have your first patient as a pseudoexfoliation patient, that's a win. You know, already big cataract out, big pressure drop. They're ideal, I think ideal first cases. But you don't have to wait for the ideal case. You can do it on everybody. Uveitic and steroid glaucoma, even in infantile glaucoma, and these are about 10 cases. I keep saying to myself, I got to put in the end. This is actually Don Winkler's. I think it's an N of 10 or so. It works in children too, less experience with that. In highly complex glaucomas too, trauma, only 3, but see the pressure drop here, 35, boom. Neovascular, why would you do that? Well, it has to be a quiet, former active neovascular eye. Avastin and laser, you can do it, just trabectome alone, boom. Retinal detachment and buccal, we had 5 such patients with a pressure of 32, and they too have reasonable pressures for about a year.